All right, should we start this? So I was asked to come and talk a little bit about transcutaneous pacing, which is a difficult thing. I was just telling Brian, we don't do it very often at the hospital. In the ER, they do it sometimes, but we always go to another method, which is a little more reliable and a little less brutal on the patient, but that's what you have out in the field, and sometimes it can be life-saving. So Brian sent me a few things, and let's just go over a little bit what this is and what it isn't, and please, I'm eminently interruptible, so ask questions, and if I don't know the answer, we'll make something up. All right, so we'll talk about transcutaneous pacing. One of the big things I've seen in the field and even in the hospital is it really needed? Is this really what the problem is? And then the second thing is we've talked about, okay, maybe it's needed, but is it actually working? And that can be difficult with this because it is a rather brutal electrophysiologic event. For a pacemaker, the energies are delivered in microjoules. And most of the time, pacemakers are a constant voltage with a variable current. Current is the flow of electrons, so they're in the milliamp range. However, defibrillators deliver very large energies in the joules, and in the amps, so thousands of times more energy are delivered and received than with the pacemaker. They all can be either external or internal. The leads can be placed in different ways. What we have, of course, is the LifePak 15 with the pads on them. And that's a big machine, has big pads and so forth. If they're implanted, you can have something this size, which is much, much more complex and variable in what it can do than that big machine. This is a computer that can do all sorts of things. This is just a pacemaker. This is a pacemaker and a defibrillator. So see the difference in the sizes and the capabilities of these two different things. All right. Oh, there we go.
Have these been used?
Just in a little old lady who didn't use them very much. It was not very bradycardic. That's probably $15,000. That's probably $25,000 right there. So if you don't get them back to me, Chief Law, can you dock their salaries? And okay, all right. All right, so what we do for emergency pacemaking is place a lead, usually through the jugular vein, sometimes through the femoral vein, into the right ventricle, often with the balloon lead, and then attach them to an external pacemaker, which is a box that can do all sorts of things. You have a pacemaker here that goes through the pads, and it doesn't have a lot of variability other than the delivered milliamperage. All right, so what are the problems with transcutaneous pacing? Well, there's a number of them, obviously. One, and we'll talk about these, one is recognizing the appropriate indications, and that can be a significant issue, even though you do have a county protocol that doesn't cover everything. The next thing, as we talked about, and I was asked to cover a little bit, was how if you fail to achieve or maintain or recognize electrical capture. The third thing is the failure to achieve, maintain, or recognize mechanical capture. In other words, whether this electrical stimulus to the myocardium is actually producing something that keeps the patient alive. It's ejecting blood to keep their organs alive. And then, of course, as I said, this is an uncomfortable thing in a conscious patient, obviously. All right, we're not going to go over the Sacramento County bradycardia protocol. You all know that, and everybody has gone over it multiple times. But basically what this says is three things. One, you can pace somebody if their heart rate's slow. They happen to pick 50. Two, they have to be hypotensive. They happen to pick 90 systolic. And three, they have to show signs of hypoperfusion. whatever that is. So that's the criteria, and it makes sense. It's reasonable, but there's lots of variables that this doesn't count for. So that's the law that you're following. I always advise you to follow the counting protocols. Most of them actually make sense, but they certainly don't cover every circumstance and don't give you the experience to recognize every physiologic situation. So what are some of the things that we should think about if we're actually thinking and not just blindly following a protocol? And I hope we do think a little bit and look at the patients actually to see what's going on and to see what your treatment is doing to the patient or is not doing to the patient. You know, even giving an aspirin tablet can kill some people. You better watch them and to see what effect it's having. So one thing, not all slow heart rates are bad. There's lots of people who have slow heart rates, especially at times, and they're doing just fine. All of you people in here, I can tell, are in tremendous physical shape, and so you may well have heart rates in the 40s when you're asleep, may even have junctional rates that are in the 40s if you have a little bit of parasympathetic tone, and you're doing just fine. You don't need to be paced, even though you're below the magic number of 50. If you think about that, what you were really concerned about is that your cardiac output, how much blood your heart is putting out, what that's doing. And that's a simple equation. Your cardiac output is equal to the stroke volume, which is how much per beat, how much blood per beat is put out, times the heart rate. So if you have a big stroke volume, you're going to be fine at a heart rate of 30, perhaps, if you're not demanding a lot of oxygen in your blood. But if you have a very bad stroke volume, your heart's barely beating, it's not putting out much blood, you may need a heart rate of 100 to try to get an adequate cardiac output, enough blood to supply your tissues. So just using that magic number of 50 doesn't cover everything. And there's a lot of physiological variables in patients. The other thing, there's lots of reasons why people may have signs or symptoms of low cardiac output, why they may be cool and diaphoretic and have poor capillary refill and have poor mentation, low loss of consciousness, decreased level of consciousness. There's lots of other reasons other than bradycardia that cause those signs and symptoms. So beware that somebody may be bradycardic and may be low output, but it's true and unrelated. They're not low output mostly because they're bradycardic. Something else is going on. So that means that we really actually have to have some good clinical judgment to decide when to do this, when it's helpful and when it's not helpful. And you don't have a lot of tools out in the field, so sometimes this just has to be clinical judgment. Plus, in accordance with the county protocols, of course, which I said they're a reasonable starting place. So it may be reasonable to try some external pacing or some drugs, depending on the rhythm, some atropine. And down the road in the protocol, it does give a place for push epinephrine, which can be actually very helpful in keeping a patient alive to get to the hospital. So to do a therapeutic trial is not unreasonable. But also realize, even if you get electrical capture and you get mechanical capture, this ain't very physiologic. You're slamming the heart with an electrical stimulus that may induce some sort of a sequential contraction, but you're losing AV synchrony. It's not pacing the atrium and then the ventricle. You're actually even losing correct sequential activation of the ventricles. It's always some sort of a bundle branch block in this. So it ain't great pacing, I can tell you that. So don't fool yourself. So the point is that perhaps somebody with a sinus bradycardia, if they're maintaining AV synchrony, even if they're 30, might possibly be better off just in terms of cardiac output than somebody paced with this elephant slamming their chest, losing AV synchrony, losing sequential activation at a rate of 80. Those have to be clinical judgments and looking and seeing what the patient's response to the intervention is. And I always recommend that you look and see what the response to any intervention you're doing is. That's your job. Your job is to keep them alive and in the best shape possible until you get them to the hospital. So let's look at something that's pretty obvious here. And here's a paced rhythm. And here you can see a pacer spike. Are you seeing that little tiny thing there? There's a pacer spike. It's pretty obvious. Then there's a broad QRS, which these usually are broad because they're activating the ventricle. And then some kind of an ST-T wave. So these are paced and captured. Here's another pacer spike here, but it's pretty obvious nothing's happening after that pacer spike. Here's a normal conducted beat. Actually, it happens to be a sinus beat. Here's another pacer spike with nothing following it, so it didn't capture. Here's a pacer spike, but with something after it, but it looks like it's the same thing as their normal sinus beat, so it actually didn't capture. It just happens to be in the same place as the P wave. So we can see what these are as we talked about. So these are pacer spikes with capture. These are pacer spikes without capture. And this is another pacer spike which actually didn't capture, but there happened to be a normal beat afterwards. All right, so Brian sent me a few of these things from the field. I guess they were, Brian, right, where there was questions. So I copied a couple of these, and let's just look at these. So this is one actually from Metro Fire that came from the field. And let's ask ourselves a couple questions. First of all, what's the underlying rhythm on the first line? And then you can see the attempts at pacing and was there capture. All right, we'll look at that one for a second, and then we'll have the answer. So this looks like a junctional bradycardia. It's a narrow complex. I don't see any P waves. There's a lot of artifact in here too, but it's probably a junctional bradycardia below 40. So below 40, does that meet criteria for pacing? Well, it depends on the other physiologic parameters in our protocol and looking at the patient. But let's say it did. Well, is it capturing? The answer is no. It is clearly not capturing. And there's a couple reasons that you can tell that. So here, if you look and you pace them out or you count them out, here's the regular bradycardia marching right through here. But look at this. Here's a pacer spike, and darn, that looks like a QRS to me, doesn't it to you? And there's something after here. Well, that is actually not a QRS. That's something called a false paced QRS or a phantom QRS, and we'll talk a little bit about more about that, how you can recognize those. But just looking at this, that here's a normal beat, and you can look at it as a normal junctional beat. It's occurring in the absolute refractory period of that phantom QRS. The other thing we're wondering if that may be a QRS. Well, it ain't, because that can't happen electrophysiologically. That's the absolute refractory period. And here we see another one, although that may not be absolute refractory period. And we'll look at a couple more of those. So look and see if your regular rhythm is marching through and if it's affected by these spikes, and then see if it's physiologically plausible what you're calling a QRS. Okay, those are a couple things to think about. All right, here's another one that came right from Metro Fire. So what's the underlying rhythm here? Well, we'll look at that. And is this paced? Anybody have a thought about this one? Anybody have a vote?
Intermittent capture is what I would guess.
Okay, that sounds like a good thing. Well, that's what I called it too. So I called this a junctional bradycardia. It's pretty slow, something around 30. This actually is an artifact right here. But I'd say this captured mostly, but there were some non-captures. And if you look here, here's a spike, then there's a broad QRS, and then there is a T wave, an ST segment and a T wave, and that's important. So broad QRS and some sort of a defined ST T wave. And that's what tells you whether this is a capture or not. Now, there are some other things that are going on here. So here's one where there actually is a failure to capture, if you can see this blue arrow here. So there's a spike, a quick downturn, and then it comes up slowly to baseline, but there's really no ST or T wave at all there. And of course, it's going to depend on the lead you're looking at. And there are some where there's actually some fusion, where the patient's normal beat was coming in, but then a spike came in, and some of it was conducted not through the normal conduction system, but through the pacer. So this one, I'd say, is mostly captured in a junctional bradycardia. All right, let's look at this one. What could this be? What's the rhythm? And is this paced? Well, we won't waste a lot of time, but let's just look at a couple things here again. So I call this a sinus bradycardia. It's pretty slow. It's around 30, something like that. These are mostly not paced. They're not captured. There is pacing, but these are the phantom QRS. And you can see here there's a quick downturn, comes back slowly to baseline, and it's not really a good T wave there. There's a couple that, in addition, you can also see the patient's regular sinus bradycardia is marching through here if you time it out there. So this is not capture. Now this one we have a little clinical information on too, but we will forget that. Let's just look at the rhythm here. So what's the rhythm? Is this paced or not? And there was a lot of question about this. There was some clinical stuff about the patient had been all right, and then he was nauseated, and then he got lethargic, and he had this rhythm, and then they tried pacing him, and they were unsure whether the pacing was capturing. I think this is the thing here. But his level of consciousness increased, and but they weren't sure if it was really mechanical capture, and then they took him to the hospital. And I think they did think later he got captured. Well, what is this? Well, this is atrial fibrillation. It's not that slow. It's 50s, 60s, something like that. So that's one question I would have. Is this capturing? Well, no, it's not mostly capturing. And there's a few things we can look at here. First, here's clearly an attempted pacing, but it has the false QRS, the phantom QRS. And also, if we count these out or look at these, although it's atrial fib, so it's going to be an irregular rhythm, these are count out with the normal atrial fib QRS. So this is not captured most of the time. There's a couple of ones which may be a fusion capture, like here and here, that maybe that's a T wave afterwards. There's some artifact there too. So I call this not capture, and sounds like they had a lot of questions about it too. And here's another confirmatory thing as we talked about before. So here's it looks like a paced QRS, but it's in the refractory period of their normal QRS. So that's not physiologically reasonable to assume. All right, well, we'll go over some of that in a little bit. This last one, I don't really know much about the patient clinically, but just thinking about the whole patient, I would have some questions. Number one, I would question whether the heart rate, whatever it was, 55, 60, something like that, really is the cause of this patient's problems. It could be. It's possible. As I said, some people who have a very poor stroke volume might need a higher heart rate, just as you do when you're in hemodynamic shock, hypovolemic shock. What happens? Your heart speeds up to increase the amount of blood put out, since your stroke volume is going to be low because your filling pressures are low. So it is possible that somebody could be symptomatic with a heart rate of 55 or 60, but I would question that because, as we talked about, there's lots of other reasons that you can have low cardiac output. Even if he suddenly went into atrial fib, you can see people that go into atrial fib and get very sick. Most people, if we put you into atrial fib right now, which we are going to do in about 5 minutes, you would decrease your cardiac output 10%, maybe 15%. But if we take somebody who's got a very bad heart, it's barely working on its own, and we put them into atrial fib, even at not a very fast rate, their cardiac output may drop 50%. They may go into shock because of that, because they're losing their atrial kick, and there's lots of physiologic reasons why that makes a difference. It doesn't make that much difference in a normal heart, but in a bad heart, it can make a lot of difference. So just going into atrial fib alone can put some people into shock or make them not look very good. But pacing them, unless you get them out of atrial fib, ain't going to help that. Also, there's lots of other things, obviously, metabolic things, drug things, hypovolemia, that can be causing this patient to be sick and having an altered level of consciousness and not look very well, other than a heart rate of 55 or 60. So the question has to come out, is transcutaneous pacing really what this patient needs? And I don't know that. I wasn't there with this patient, but I would question it. Then, of course, is it working? Are you having electrical capture, which in the parts we saw at least, they weren't. So clearly they weren't having mechanical capture. But they did say at some time in there that the patient's level of consciousness increased. Well, if I take one of these pads and put it on you, Brian, and pace you at 100 milliamps, you'll wake up a little bit too, you know. So it may not be the physiologic effects of the increasing the heart rate that did that to the patient. So this is the same thing we talked about before, but please let's think about the physiology of the patient, not solely the county protocol. All right, let's look at just a couple others as we're finishing up here. So to recognize electrical capture, you'll look for the pacer spike, followed almost immediately by a broad complex QRS. It's not going to be narrow complex because in this setting, you're clearly pacing the ventricle. You're pacing everything, really. So that, and it's followed by a reasonable ST segment and a fairly defined T wave. Now, obviously, this varies depending on the lead you're looking at and so forth, but that's really what you're looking for. This clearly is not a capture. It's one of these phantom QRSs. Why? Because we have a spike followed by a very narrow complex, then slowly comes back to baseline. There's no ST segment, no T wave. So that kind of looks like a QRS, but it ain't. It isn't a captured QRS. Here's a normal beat. That's looks like a sinus beat. Looks like there's a P wave ahead of it. Here's another normal beat. Looks like a sinus beat. Here's another captured beat. And down here, we have a whole bunch of captured beats. So this is intermittent capture in this scenario here. What about this phantom QRS thing we're talking about? So it's not so difficult if you just have a spike and then you have nothing afterwards. That's pretty easy to know that that's not an electrical capture, right? But this can be confusing, this phantom QRS thing. Well, why is that? Well, I think it's the same with the 20. I know this is the 15, is it? I know in the 12, and I'm pretty sure it's the same in this. There is a blanking period that Physio Control, and I think Zoll does too, puts into their thing where it actually doesn't record, it doesn't look at electrical activity for about 40 milliseconds after the pacer spike. And the reason is if they did that, they'd have these huge voltages looking at that because they're putting a lot of milliamps into it. But then after that, whatever it is, 40 milliseconds or so blanking period, Then it starts looking at it again, and you may be seeing some of that activity on the EKG that is this false QRS, the phantom QRS. And that's easy to mistake for a QRS. But as I said, look for a very rapid downstroke, usually but not always, it's opposite the pacer spike. Very rapid downstroke or upstroke, slowly coming back to baseline, and then no real defined ST or T wave. And that can help you. The other clue is that these phantom QRSs, the voltage of them, so how high or low, what the distance is here and here and here, as you increase your output, the milliamps on the physio control, they get bigger, where that's not going to happen if it's just a true myocardial response to it. So see how this happens at 40 milliamps, it's response is here, 60 milliamps, it's bigger, 90 milliamps, it's actually bigger than that too. Why might we have a failure to achieve or to maintain electrical capture? You may have electrical capture for a while, maybe intermittent, it may go away. Why can that happen? Well, there's lots of reasons. One, there may just be a high capture threshold, and that's something that's always measured when a pacemaker is put in. What's the threshold? How much energy, what's the current that has to be put in to the myocardium to achieve an electrical capture? Well, there's lots of reasons why that can be messed up, and there could be myocardial ischemia, where the heart's not getting enough blood supply, hypoxia, acidosis, electrolyte imbalance, especially high potassiums. You take somebody, we do this in the operating room every day, we give them whole big loads of potassium to arrest the heart, and then we take the aortic cross clamp off, and depending on what's going on, the heart may just sit there and just kind of look at you doing nothing. You can try to pace that heart, put an electrical stimulus in it, and it sits there and does nothing. It's because the patient still has a very high potassium, and you have to let that wash out in order for them to have a response. Hypothermia can cause a lack of response to pacing stimuli. And in fact, if somebody's very hypothermic and very bradycardic, you probably should not pace them for a couple of reasons. One, you can induce ventricular fibrillation, and hypothermia is a cause of ventricular fibrillation. It's much better if you let them at a slow heart rate. And the second thing is if they're really cold, their metabolic demands in the rest of their body isn't very high, and so it's a relative contraindication not to electrically pace somebody who's bradycardic just because of hypothermia. And you aren't going to be able to do it if they're really hypothermic anyway. So a high capture threshold could be one reason why you don't achieve electrical capture. I don't want to get into electricity too much, mostly because I am not an electrical engineer, but there is such a thing as impedance. So the resistance of flow of electrons, of course, across anything, and that happens across the thorax, and that can be due to lots of things. If somebody has a lot of emphysema and you're trying to put it through the lung, if they've got, even if you're mechanically ventilating them and you've got a bunch of lung in between them, that's not a very good media to transmit the flow of electrons. If they've got a pneumothorax, for sure. If they've got a big hemothorax, that can be a problem. If they've got a big pericardial effusion or pleural effusion. So there's impedance issues that can prevent you from achieving capture. There can be things that you can, and so you can change some of those things, like if they have a big pneumothorax, you can needle decompress that. That's getting into a couple protocols, however, then wouldn't you be? So that can be a problem. But if you can affect any of those changes, that's helpful. There are some things you can do is with electrodes, and so it does matter what your dipole is, where you're placing these these pads. And of course, the ones that we use are anterolateral because it's easier to do, but that doesn't always work well. So if that doesn't work, try an anteroposterior. And make sure that the surface contact between the electrodes, between the pads and the patient is good and clean. That may mean, well, I don't think you have razors on board, but it may mean you have to shave the patient or certainly get sweat and blood and stuff off of them, dry it off, because if you don't have a good contact between the electrodes and the skin, that may be a problem. Obviously, you want to check your batteries and check the connections to make sure that they're all okay. One thing you can do is, and I'm sure you do this, is increase the energy output. If they're going to capture, most people capture with transcutaneous pacing someplace between 20 and 140 milliamps. If you get above 80 milliamps, that tends to hurt if you're conscious. The physio control, I believe, has a range of 0 to 200 milliamps. Does anybody know if that's true, or am I lying? I think that's true. Okay, you can check that. But anyway, it's something in that range. And the Zoll is something similar to that, 0 to 140, I think. So you can increase the energy until you achieve capture. But if you don't get it at 140 or something, you're probably not going to get it at 200. Forget about this. In this, I'm pretty sure you don't have an adjustable pulse width. Some of these things do have adjustable pulse widths, because think of what we're doing here. The thing that gets something to defibrillate or to pace means supplying sufficient current to the myocardium for a sufficient period of time. So what can you do? You can increase the current or you can increase the time. In your setup here, you don't have the capability of adjusting the time. What it does have, and I've found that not everybody knows this, there is a mode in here where it could be what's called demand. And what that means is it senses if the patient is generating their own QRS, and then if it's in that mode, the demand mode, the non-synchronous mode, then it says, oh, I'm not going to pace here because the heart already put out an electrical event. The asynchronous mode, the non-demand mode, it's just going to fire no matter what's going on. Can you think of a danger to that scenario? Maybe R on T. Yeah, you can induce ventricular fibrillation because it's not paying any attention to where the patient's own electrical generation is, and you could easily put an R on T in that event and induce ventricular fibrillation. So this isn't without some risk to it. You know how to place pads. We don't have to do that. All right, so let's just look at another one or two of these things just to reinforce what we said. So here's pacer spikes, right? Looks like a QRS. Is this capture? No, it's not capture. It's one of these phantom QRSs. Goes acutely down, comes back to baseline, no real ST or T wave. The other confirmation of that is here's the patient's intrinsic rhythm here, which is occurring in the absolute refractory period of this QRS, if that were a real QRS. It ain't a real QRS, it's a phantom QRS, so this isn't real. It's not capture. Is this capture? Well, we could look at a couple things. One, we can see the patient's native rhythm coming through here on its own. This one you don't see, but if you pace them out, the patient's native rhythm is marching right through. And indeed, we here have a phantom QRS occurring in the absolute refractory period of the patient's native rhythm. That ain't going to happen. So we know this is not capture. All right, so we talked about electrical capture and recognition of that. Let's talk for a minute about mechanical capture, which I'm told is an issue with some, which is understandably a problem. Well, what are you going to do? Of course, you're going to feel for the pulses. You're going to palpate for the pulses. You can try to take a blood pressure, probably a manual better than the automatic. The automatic, when they're flopping around like this, can be problematic. You don't have Dopplers or arterial lines in the hospital. We often have those things, and you can actually see if there's a pressure pulse generated. The problem with these things, you can mistake things for a pulse. If they're twitching and their skeletal muscles are twitching a lot and they're jerking around, it's pretty hard to feel whether that's really a pulse or whether that's just some muscle contraction that you're feeling. Also, something that is not widely appreciated but can occur, and certainly with CPR, and I've seen this, is you feel in the groin or maybe you feel up in the neck and you feel, oh yeah, I feel a pulse when you're compressing. Well, it may be that you're feeling a venous pulse because the veins right next to the arteries in the femoral region, the femoral vein is just medial to the femoral artery. In the neck, the internal jugular vein is just lateral to the carotid, so they're not far apart. And if the patient is not in AV synchrony, so the atrium beating and then the ventricle, atrium beating and then the ventricle, say they're in heart block or something, and you're just pacing them, even if there's contraction of the ventricle, if the tricuspid valve, the valve between the atrium and the ventricle, is widely open, you can get a huge rush of blood back through the right atrium, up into the jugular veins, down the inferior vena cava into the femoral vein, and it feels like a pulse. It is a pulse. It's a venous pulse. It's not as high pressure because it's right-sided as it would be a normal arterial pulse, but you can feel a pulse, and it's called a Cannon wave. So that can be mistaken for an arterial pulse, especially when there's this AV dysynchrony, which you always have when you're pacing with these patients or with this device. Arrhythmias can make it difficult. These people often have arrhythmia. They have intermittent capture, so that can make it difficult to see if it's really a pulse. So use your O2 sat waveform, right? If you can see a pulse on that, that means there's some capillary flow. Now that can be difficult too because there can be a bunch of artifact, and these patients may be so sick that you're not, even though they're having an effective contraction, it's not getting out to their distal capillary beds because they're all shut down. So somebody in bad cardiogenic or hypovolemic shock, you may not get a very good plethysmogram, a digital oximetry on, because their distal capillary beds are really shut down. But that's another way of looking at it, and that's a confirmatory thing if you've got a good plethysmogram on that O2 sat monitor. You can look at if they're intubated or if you've got an end-tidal CO2 on a nasal cannula or something, you can look at that and see if they've had a marked increase in their end-tidal CO2, reflecting better perfusion. Look at them clinically, see what their capillary refill is and so forth. That's part of your routine assessment for what perfusion looks like. See what their skin turgor is like. And then if you saw them before they were being paced and you see them after they're being paced, how do they look? Were they totally out of it and looked terrible before, and then you started pacing and they start waking up and talking to you and say, get this thing off of me, where they were unconscious before? Well, that's an indication that something may be going on. Maybe just that they were kind of sleeping and you woke them up with this. So see if there's been a neurologic change. And here's just an example of captured pacing here. There's a pacemaker, a wide QRS, a T-wave. This is electrical capture. And here's an end-tidal CO2, which it becomes elevated. So another confirmatory thing that there is metabolism going on and perfusion. Same as you would for ROSC and CPR, right? Well, so why might they not achieve or maintain mechanical capture? Well, a lot of the same things we talked about why they wouldn't get electrical capture. So what we're really looking for in mechanical capture is there enough ventricular ejection to produce a pulse someplace and tissue perfusion. That's really our goal with this, right? So yeah, we've got an electrical stimulus. Yeah, it made an EKG that we confirmed as capture, electrical capture, but I guarantee you, you can have electrical capture and have the heart going like this and really doing nothing mechanically or nothing effective mechanically. Just like PEA, right? So you can have the same thing, but you induce the electrical activity. So there's a lot of reasons, the same thing. Myocardial causes, the heart muscle just ain't working well enough. They've just arrested. You got them back with some sort of electrical activity. Maybe you're pacing them with some sort of electrical activity and you got capture. But that heart is such oxygen debt, it's acidotic, the myocardium's acidotic, it ain't beating effectively. What do you need to do for that? Just pump on their chest, CPR. This myocardium isn't making it. And there's a lot of other reasons. They may just have a bad heart for other reasons, not from a heart attack. I guarantee you, if they're very, very hypoxic or very, very acidotic, that myocardium, even if it may get an electrical capture, isn't going to beat well. And we see that every day in the operating room. So you have to correct those things, and the same thing with hypothermia. There are other non-heart muscle problems too that perhaps can be taken care of. They may not be ejecting much because they're bleeding to death or they're very hypovolemic. That makes sense, doesn't it? You know, so you have to correct the hypovolemia. They may have things which you're not going to take care of in the field, but they may have like pericardial tamponade. They may have a tension pneumothorax, which is kinking off their superior and inferior vena cava and their pulmonary vessels, which makes it impossible for their heart to fill. And of course, they're not going to eject then. So there are other things that you have to be thinking about that may be causing this failure to achieve mechanical capture. And they may have developed their bradycardia because of these other problems, their hypoxia or something. You correct the other problems and you'll correct their bradycardia. Pacing them when they're severely hypoxic, severely acidotic, or they're tamponaded and their great vessels are kinked off ain't going to work. You aren't going to resuscitate them. You have to correct the basic problem. The other thing we talked about is about patient discomfort. Well, that's obvious. Why is this painful? Well, I mean, it's obvious. It's you're delivering an electric shock to the skin, and it stimulates the skeletal muscle. It's like a cramp, you know, and except you're doing it at 80 times a minute. Also, it is just an electrical shock, obviously. The pain is related to the current density. These are pretty large pads, so the current density isn't too great. But I guarantee you, if you get probably about 80 milliamps at least, it gets pretty uncomfortable. If they're unconscious, obviously it doesn't make much difference. But if they then become conscious because of the wonderful care you're giving them, then you may have to consider sedation, and that's part of the protocol. Midazolam is in the county protocol if you need it. And they may initially have some capture or intermittent capture, and then later they fail to capture. So all the things that we talked about before, if the pads come loose, are they blood under them, is there sweat under them, have they developed a pneumothorax because you intubated them and they had a simple pneumothorax and now they got a tension pneumothorax. You still have to look at the patient and these other technical things having to do with the electrodes. And if you do this for quite a while, you're likely going to burn the skin, especially at the higher milliamps. So this is not without some harm, obviously. But you're probably going to have to sedate these people if they're really awake, and you're doing this for some time. Get them to the hospital is what you really need to do. All right, let's finally just go over some of these things again, just as a little review. And let's look at true capture, the pacer spike, a wide QRS, followed by a real ST T wave, right? So these are all true capture. Here's a spike with no capture here and here. That's pretty obvious. Here's a spike with capture. This isn't difficult to tell. The spike with no capture or nothing after it at all, not even a phantom QRS. That you're not going to miss. But here's the one that can be difficult, the phantom capture, the false QRS. So again, there's the pacer spike, usually with a abrupt vertical downstroke, or it could be an upstroke depending on the polarity, followed by going back to somewhere near baseline, but not a real ST wave. And again, you may have to look in some other leads to get that. The other thing we talked about is, remember that the phantom QRS, the voltage increases as you increase the output from your physio-control pacemaker. And finally, look for underlying rhythms, pacing through to get another idea whether this is really capture or not. So these are the underlying rhythm marching right through. And then also looking if these false QRSs occur in a refractory period or vice versa. So just a little review of what we were talking about. One thing you can, if you're having a problem with it, you can try putting your diagnostic limb leads a little further away to get away from some of the artifact. It helps sometimes. And as we talked about, this does have a demand mode. So if you aren't getting routine capture, it may be because it's being suppressed, it's being inhibited because it's in demand mode, where it's saying, oh, I see something electrical going on, I'm not going to pace. So check that. But if you're in the asynchronous mode, where it's not paying any attention to what's going on with the patient's own electrical activity, beware of the risk of R on T phenomenon. So you can be sitting there looking at it, and he has a bradycardia of 40, but he's alive, and you've just killed him because you did an R on T and put him into ventricular fibrillation, and you're not looking at him because you're busy doing your PCR. Look at the patient. What else can we do if you're having non-capture with either electrical or mechanical? Obviously, we can increase the power output, make sure that the pads are in good position and working well, make sure you're, whether you're in demand or non-demand. You have to correct the other problems. If they're hypoxic, if they're really acidotic, you've got to correct those before this is going to have a chance to work. This rarely happens, but obviously you've got to pace them faster than their own intrinsic rate. And we already talked about correcting the non-myocardial issues. And this seems a little silly, but make sure the patient is actually alive. That may be a reason why you can't achieve electrical or mechanical capture. They're dead. And this sounds funny, but I have actually had this in the hospital when I came in the morning, and there was a patient who was on a ventilator, who was on a pacemaker, who was on an intra-aortic balloon pump, which was triggered by an electrical signal. So he had pulses going up, had an arterial line and a Swan-Ganz catheter and everything. And I went in to look at the patient, and I asked the nurse, so how's the patient? She said, well, he's been stable. And I went in and looked at him, and didn't look so good. And I came out and said, well, he's actually dead. And she got mad at me. She said, no, he is not dead. Look, he's got a pulse, which was the pacer spike, inducing the intra-aortic balloon pump to work. And he's ventilating. Well, he's on a ventilator. He was dead, D-E-A-D. So make sure the patient isn't dead, because that can be a reason why none of this stuff works. Yes?
I know you don't necessarily have a lot of experience with the LP15, but it does have an option on there while we're pacing. If we push pause, it'll lower the pacer rate to 25% of whatever it's set,
Okay.
to 25%, so you can see the underlying rhythm or the
Good.
intrinsic rate. Do you see any issues with that, or do you? I guess the concern would be, would we potentially lose capture?
You'll probably lose capture for a little bit, but that's actually a good thing rather than just turning it off. So you can see what the underlying rhythm looks like, to see how that looks, the complexes compared to what you're interpreting perhaps as a capture, and to see if he's maybe, because there's a lot of artifact, maybe he's in ventricular tachycardia or something else that you're not recognizing. No, that's a good feature. I did not know that feature was on there, but sure, that's a reasonable thing to use. Keep cross-checking to see what's really going on with the patient. Yep.
So I was curious, at what point when you appear to have electrical capture, but you're not able to achieve a mechanical capture, and you keep increasing the milliamps, because I believe we do have a case where we had some milliamps up quite high.
At 190.
Yes. At what point do you go, okay, something is not working here, and back off and just recheck everything, or you come to realize that maybe this is not going to work?
Yeah. Well, a very good question, and it means looking at the patient and using some clinical judgment, which isn't in protocols, unfortunately. And you're very right. So if you get much above 100 and it's not working, I'm not saying it's never going to work. Above that, it absolutely can. But if you're getting above 120, say, and you're not getting electrical capture, by those things we were looking at, those are the clues to look and see whether you get electrical capture. But then to see whether you're getting mechanical capture. Most of these, or many of these people are very, very sick, and as I said, you may well not get effective mechanical capture. So if you're not getting the results that you need, and yes, dial up your milliamps, absolutely, go ahead, especially if they're not feeling anything, and see what happens. See if there's a change in the EKG, or if you think this may be phantom QRSs, the thing we were talking about, the voltage of those phantom QRSs is going to progressively increase as you increase the milliamp output of the physio control. So look for those sorts of things. If all of a sudden, say you're at 120 and it doesn't look like it's capturing, or you're not sure, and you put it up to 160, and then you see an actual change, a wide QRS and a real STT wave, then you've done enough, The mechanical thing is all the things we just talked about. See if he's getting better. And you know what? If he's not getting better and he really looks like he's dying, and you really don't know what's going on, maybe I feel a little pulse and maybe I don't. I'm not really sure. He's looking really bad. I don't know. I'm not getting a waveform of this. Do CPR. Yeah.
To tag on to that, in our protocols, Sacramento County protocols, we can also give push dose epi.
Yes.
And so could you elaborate on, are we increasing chronotropy or contractility, or what exactly would the epi provide that maybe the pacing's not?
Yeah, it does both of those things. So depending on what dose you're giving, but epinephrine is both a beta agonist, which has positive chronotropic effects, increases the heart rate, and inotropic effects increase the strength of contractility of the myocardium. And honestly, in some of these people, especially if you're, and I'm glad they put that in there, and they put it in for other things. Epinephrine is a terrible, awful, terrible drug. It saves people's lives, however, and it's not something good to be on for a long time. It clamps down your viscera, it does all sorts of bad things, but it may well be a better thing to do than using this pacemaker if the pacemaker isn't working and isn't affecting what you need. Even if the pacemaker is getting the electrical capture that you were talking about, geez, he still really looks bad. I don't really feel much of a pulse. Well, this may be a failure of mechanical capture because this heart is barely contracting, in which case you do have another tool given to you by the auspices of the County of Sacramento, epinephrine, which does exactly as you were saying. So yeah, escalate to that for sure, as you do in other shock states, which is in your protocols, which I'm very happy about. I was never terribly happy about dopamine protocols and so forth because, I don't know, Chief Law, what you thought about it. You were in the field a long time doing stuff. By the time you get down to a dopamine protocol, you have no idea what rate you're really giving it at and so forth. But you can give a little push dose epi and keep people alive for long enough to get them to the hospital and get them to another level of care. I'm very happy they did that. What's been your experience with dopamine and epi? What do you think about those things?
I have not had the opportunity to use the push dose epi because I have not.
Yeah.
So I did like the dopamine, but if people used it wrong and just ran it wide open, which
Yeah.
was a problem, it made people pretty sick. And
Yeah. Depends on your
used
transport times.
properly, it was helpful.
Yeah. Just use some common sense. That's probably the biggest tool that you have. All right. That's all I have, but can answer obviously any questions or call-ins. Do we have call-ins? Yeah.
So what would you recommend? Let's say we're pacing someone and we've got capture, their perfusion's increased, meditation's increased, we've got a good blood pressure, and we show up to the hospital. How are we transferring these folks to the hospital?
Transfer care.
That's the $1 million question.
That's the number one issue.
Appropriately.
Yeah. Clearly I don't know the answer because now we're talking about important things like money, because who's going to keep that thing on? You know, hopefully what can happen, although in the ER this is probably not going to happen, you can get somebody, we can put in a transvenous lead pretty quickly. Takes a jugular stick, throw it down, have a balloon up, and if they've got some contractility, and get them paced. In the ICU we can do that very quickly. In the OR, maybe not, or in the ER, maybe not so fast. Yeah, I mean, just the logistics of doing that. You know, honestly, if they're life dependent on that event, and you've gotten capture and it was difficult to get that, taking off your machine and putting it on, I just doesn't seem terribly logical. You know, until you establish another backup like that, but. I understand that that may not happen and for various reasons. Or there's some patients who, yeah, it's capturing intermittently. They've got actually a viable rhythm underneath that. They just weren't doing so good. That's a different situation, you know. Okay, let's switch over here. So I think it depends on the importance of the intervention that you're doing at that time and whether that's really made a huge difference in keeping them alive in terms of how you affect that transfer. But I can imagine that's a problem sometimes, huh?
All
Yeah.
I've yet to get one done correctly without having to either remove ours or leave our monitor with them and gone basically out of service and waited until they were able to take them to have surgery.
Yeah, I clearly don't have an answer to that, but that's something that can be brought up at the EMS divisions with the ERs and stuff like that. But honestly, if you're truly keeping the patient alive at that point and it's the best option to have you go out of service, that's worthwhile. Having you sit 4 hours on the wall because they don't happen to have a bed and you got somebody with back pain, I have some more problems with that.
Would it be a feasible option to have hook up both the ongoing pacing and the replacement pacer at the same time, both on demand, and have the new one at a slightly higher rate? And if they get to that rate, then you know you've got them captured? Is that feasible, or is that a
I mean, I guess
ridiculous idea?
that would be feasible, but that could be fraught with a bunch of problems. For one, demand assumes you're going to have a quiet electrical milieu. Chief Law, I used that for you. Because demand really, if it gets some noise in there, it's going to stop pacing, some artifact in there. So I see that fraught with some problems. Plus, you're going to obviously have to put your pads on a different way. I mean, yes, you could put one anterolateral and one posterior, but you're not sure if that other one's going to capture. And if you're winning the race with the one, I'm not sure I'd try to do that. Again, if this is truly an immediate life-saving event. Now, hopefully, in answer to your very reasonable question, keeping you out of service and just sitting there, people don't, if they're conscious, they don't tolerate this very well for very long unless you've got them pretty sedated. So hopefully they're going to expedite this life-saving procedure. We don't leave people transcutaneously paced in the hospital for very long at all. That's an emergency to put in a temporary emergent transvenous pacer system. And hopefully that would be occur fairly quickly, but different hospitals are different with different capabilities and so forth, so I can see that could be a problem. Good question, though. Yes?
Are there any effects to pad placement if you reverse the patches, if you put them on 180 degrees backwards from what you should have?
Theoretically, and this is only theoretically, your cathode should be anterior and your anode posterior, positive anterior. I'm not sure that makes that much difference, but theoretically maybe. Anything else?
I just feel like I don't really have a good grasp. I read all of our pacing PCRs and all of our cardiac arrests, and what I have seen in some of our pacing calls where we are not two trends. We are not actually getting even electrical capture, and we've perceived that we have. But then, when is it appropriate? I think Shani asked this, and I still have questions. When do we move on to Plan B? How long do we try and pace and just increase, and you're not getting any change? Because what I don't see is we don't ever move down to Plan B or C.
A terribly good question. This escalation should be rapid. If they're truly life dependent on this having an effective outcome, so you can crank up that MA quite quickly, but then you have to be able to recognize it, and then be able to recognize the mechanical capture with all the tools, hopefully, that we talked about here. If it isn't working, and I forget, somebody else, you're not sure if it's working. I don't know, he really still looks terrible. I don't get plethysmography. I don't know if I feel a pulse or not. I don't, just like you would for somebody with a cardiac arrest. The default thing is if you don't know, you may have a pulse. I don't know, he looks terrible. You do CPR, you do push dose epi. Escalate fairly quickly, a very good point. Don't sit around for 15 minutes. If it's that patient with the AFib and a rate of 60 and maybe has a blood pressure of 89, and maybe has a pulse rate that's recorded someplace at 49, maybe they just meet criteria and they're kind of funny. Yeah, but I got a pulse, skin turgor's not that bad, and so forth. That's a different patient than the patient who's got nothing, or has got a heart rate of 15, underneath there or something like that and looks terrible. A terribly good point, and again, clinical judgment, Don't screw around with this for long periods of time if it ain't working. And if you're not sure that it's working, it probably ain't working.
You said a couple times, like a couple ways to see if they're perfusing better would be the SpO2 or the pleth to show, and then also capnography would show perfusion. So if those two things were on with, an identification of a mechanical pulse, then you could be more confident that you had mechanical capture and improvement, right?
Yeah. Mm-hmm. Those are a couple tools that you can look. I mean, obviously looking for the pulse and then seeing what's happening with the patient. But don't forget that, and you guys know better than I do. Don't get me in trouble with county protocols, but it may well be that these patients, yes, have a true bradyarrhythmia that is harming them, but they also have a cardiomyopathy due to an acute heart attack or something. If their heart muscle ain't working well, they may need both some rate increase and some inotropy. So they may need epinephrine and the pacing. Although often the epinephrine, to your point, because it has positive chronotropic effects, will actually increase their rate anyway. But they may need both.
That brought another thought to my mind. What is the problem of trying to do a 12 lead after you have started pacing? That is another trend that I noticed in our review, and it would be helpful if you could explain to people
It's going to be difficult at best to get anything diagnostic out of that. Now, certainly looking at different leads can be helpful because you're looking at a different dipole and you may see the pacing artifacts different from different viewpoints. But to get a true diagnostic picture, of myocardial ischemia while you've got these pads on like this and you're malpositioning the leads and there's all this skeletal muscle artifact, it's probably not going to be helpful.
So if we're gonna get a 12 lead, do it before we start pacing.
What makes me think of something also?
Tell me
What's
when you
your
wanna wait.
thought process on atropine? I know the protocol's written that we're not giving atropine if there's a MI or a STEMI, and that if there's a high degree block, to go straight to pacing.
It says
Yep.
pacing without delay. It does not
Correct.
say do not give atropine.
Yeah.
Which is a key.
I think at the high degree block, it's typically wouldn't work.
I've had it though. And so I think it's a common misperception in the protocol that it says if they're in a complete block, go directly to pacing.
Mhm.
I guess the point I'm trying to make is that's actually not what it says. And the protocol revisions that will be coming out not until next July for dysrhythmias are specifically going to be stating more clearly that if it's not one of those high degree blocks, to give atropine before we.
Yeah, that's kind of where I was going with it actually, was
Okay.
that what is so the discussion is when you give atropine that you're putting more oxygen demand on the heart, and in case of a MI, you're increasing ischemia and potentially infarct. Is atropine really affect oxygen demand like that, increasing the heart rate to, whatever it does, 100?
Yeah, I have a little problem with that too. It's probably not that harmful, but follow your protocols for an MI. So what you're really trying to do when you have myocardial ischemia is balance myocardial blood flow, how much blood you're getting down the coronary arteries, versus myocardial oxygen demand. You obviously don't want to have a high oxygen demand if you can't get blood to that heart muscle. And that's the point about this. What are the determinants of myocardial oxygen demand? There's a lot of things, but mostly it's heart rate and blood pressure. So you don't want to have a fast heart rate, and this is where it comes in not giving atropine, because that increases myocardial oxygen demand, and you don't want to have a high blood pressure. However, you want to have enough blood pressure to perfuse your coronary arteries, even though they may be partially blocked, and you want to have enough cardiac output to perfuse your heart and the rest of your body. So you don't want to have severe bradycardia, but you don't want to have tachycardia, and you don't want to have severe hypertension, but you don't want to have hypotension either. As in most things physiologically, you're looking in the middle and thinking about it physiologically. But that's the reason that it has come up in some EMS circles, and LEMSA is not giving atropine in the face of a STEMI or myocardial infarctions, because it could increase heart rate, which subsequently would increase myocardial oxygen demand.
And how does that compare to the same demands put on it by pacing?
Pacing will increase myocardial oxygen demands too, and God knows what else it does. I mean, it's such a pacing, like transcutaneous pacing, is such a bizarre physiologic event with the skeletal muscle stimulation if they're awake, stimulation of their adrenals and their epinephrine output and so forth. It actually probably increases myocardial oxygen demand more than just pacing or by atropine or something like that. I am unaware of any studies that have occurred with that, but maybe there are some. So transcutaneous pacing should only be an emergency and a short-term event. It isn't for a long term. Anything else? Good questions. All right.
Thank you.
Thank you.
Thank you.